Okay, so Assalamu alaikum and good morning, everyone. Welcome to a brand new episode of Medet CR. So, as usual, we'll start with our speakers introducing themselves, Dr. Ahmed Al Hamadi, Dr. Muhammad Qasim, and our case discussants. And then we'll give the floor to Dr. Muhammad Qasim. So, I think we can start.
Assalamu alaikum everyone. Dr. Ahmed Hamadi, consultant infectious disease from Tawam Hospital. Also recently joined the faculty UA University as an adjunct assistant professor. Um, my interest is in infections in immunocompromised patients. We also do general ID, so we have a very good case today to discuss, inshallah. Dr. Muhammad.
Thank you, Dr. Ahmed, for joining us. My name is Dr. Muhammad Qasim. I'm a graduate from internal medicine residency in SKMC. My main interests are in critical care and acute medicine. If the discussants can introduce themselves.
Hi, my name is Mira Shamsi. I'm a fifth year medical student and I'm currently doing my pediatric rotations. And I'm still exploring. I don't know what specialty I'll be choosing.
Oh, we have one discussant today only.
Okay, then, Dr. Muhammad Qasim, I think we can
All right.
start. Yeah, we just
So
have
the
one
case
Dr.
today is, it's about a 37 years old male with a history of previous cardiac surgery. Comes to the emergency department with 1 week history of fever reaching up to 38.7. Before going into taking history and physical exam, I just want to say that taking history and physical examination, I think, are the most important things in diagnosing a patient with fever. And it's an ocean of information about diseases and syndromes that can present with fever alone. So a detailed history and examination are the most important thing. After that, you can send your investigations tailored according to the history and examination and reach to diagnosis and treatment. So, Dr. Amira, if you have this patient in ER, which questions would you ask him?
When did he have the cardiac surgery?
It was when he was about 20 years of age.
And if there are any associated symptoms like sweating, palpitations, tachycardia, tachypnea.
Okay. So the patient comes in with 1 week history of fever. The fever is episodic. It has no specific pattern. It resolves with paracetamol for about 5 to 6 hours, and then it reoccurs again. It's associated with chills and rigors and generalized body aches. He was doing well before that. He never had such episodes. He denied any associated symptoms. Do you want to be specific what associated symptoms you're looking for?
Sorry, doctor, I couldn't hear the last bit you were talking.
I'm asking if you want to be more specific about the associated symptoms. What associated symptoms you want to ask the patient for?
I can't hear anything. I think I'm having an internet connection problem.
Hello? I think we're having a technical issue. Can you hear me?
I think Mira is having few connection problems, Dr. Muhammad, so I'm just going to check with her and get back to you.
Okay.
Hello?
Yes. Hi.
Yes, I think now it's working.
Okay.
I'm sorry
So
for
as I was saying, the fever has been there for 1 week, reaching up to 38.7, measured at home. Took paracetamol for that, and it recovered, but then happened again. It keeps on happening every 5 to 6 hours. He denies any other associated symptoms, but he does have chills and rigors and generalized body ache. If you just want to be more specific about the associated symptoms, what do you want to ask the patient for?
So let's stop here, Mohammed
Okay.
and
Yeah.
Mira. Okay, so we have this patient who's a 37-year-old. He has a history of cardiac surgery, right? So we want to find out what was the type of cardiac surgery and what was the reason for cardiac surgery, right? So is it a
Yes.
congenital thing, or is it something that he developed in the way that requires the surgery? So Mohammed, can you tell us more about that?
Okay, so he had a mitral valve replacement with a metallic valve at the age of 25, and the reason was because he had a rheumatic heart disease, which required eventually he had a valvular failure and he required a valve replacement.
Okay, so and then after surgery, so after surgery is also essential to find out if there are any complications, so either infectious or non-infectious, right? So he has now a prosthetic valve that puts
Correct.
the patient at higher risk, including, for infections and non-infections. So you want to know whether there are any acute or chronic complications that happened from the surgery immediately or later. And you also would like to know the function of the valve, the most recent echo. So tell us more about that, Mohammed.
Okay, so the patient didn't have any complications after the surgery. He has been doing well and he didn't have any complications. His last echo, as per the patient's words, it was the doctor told him everything looks okay and he needs to continue on his medications. He never had complications after the surgery, and he checks up with his cardiologist every 6 months to 1 year.
Okay, sounds good. Okay, so Mira, what do you make from the symptoms the patient is presenting with? Anything specific or?
That the fever comes and goes, and it's relieved by paracetamol. So,
What other symptoms does he have?
the chills and the rigors and the body aches.
Okay, anything comes to your mind when you hear these terms?
It can be an infectious cause.
Can you be more specific, like what kind of infections? So fever, rigors, body aches.
Viral or bacterial.
Okay, maybe more toward viral, right? So from the initial impression, you get the impression that maybe more toward viral. We don't know yet whether he had any like sore throat or any cough. So you want to ask about that as well, right? So you have to
Correct.
form a differential in your mind to try to tackle the problem system by system and try to understand the reason behind the
So the
patient fever.
patient denies any other associated symptoms.
I'm sorry, I'm having connection problems again.
No.
Okay, so we would like to apologize to Dr. Ahmed and Dr. Mohammed and our attendees. Amira is having some technical problems again, so she's just gonna leave and re-enter the session.
No
That's
problem.
fine.
We apologize for this inconvenience.
No, that's okay. Okay, so she just joined again. Mira, can you hear us?
Hello?
Yes,
Hello?
we can hear you.
Yes, I'm sorry for that.
That's okay.
No problem. That's fine. Okay, so
Right.
Mira, what else do you want
so-
to know about?
If there are any like family members who have been having the same symptoms like fever and anything else?
Okay.
That's a good
So
question. Yes.
no one at the family had similar symptoms, and no one has any viral illnesses going on. It's just him.
Right, and then we have COVID now, so it's very important to also rule that out. Any sick contacts, anyone positive in the family.
Definitely.
Yes, and any recent travel history.
Yeah, we will
Okay,
come
that's
to that travel, but before that, right? So you want to do a review of system to try to find out if there is any other symptoms that are pointing toward a specific part of the body or system.
Maybe I'll ask about conjunctivitis, if there are any, if there is any redness of the eyes or.
Okay, you can be more systematic and basically go top to bottom approach, just to not forget anything. You can start from the head, asking about headache, neck stiffness, photophobia.
Yes.
And he denies that. And then you ask about any sinus tenderness or signs of symptoms of sinusitis, and then otitis. Then you go down to the throat, ask about sore throat lymphadenopathy. Then you go down to the lungs and ask about if there's any cough, dyspnea, or pleuritic chest pain. And of course, in our patient, we shouldn't forget endocarditis, which we should ask about recent dental or any procedures, and cardiac history, if he had any surgeries, or if he has complications of endocarditis like back pain, new skin lesions. It's important to ask about that. And you go further down and ask about the abdomen, if he has any abdominal pain, change in bowel habits, more importantly diarrhea, if he has any nausea or vomiting, which also can point you towards a GI infection or process. And then you ask about the urine, if he has any dysuria or back pain like costophrenic angle pain or tenderness, and if he has any suprapubic pain as well. In females, you can also ask about any discharge or dysuria pointing towards pelvic infections. In men, you can ask about signs or symptoms of prostatitis. And then you can ask about the integumentary system, if he has any pain, tenderness, or swelling or erythema in any specific part of the body. Don't forget to ask about the joints as well, if he has any pain or swelling on any one of the joints, which can be an infected joint or a complication of an ongoing infection. And you can ask the patient if he had or has any indwelling catheters. And with that, you can also ask about IV drug abuse, like any recent cannulation or intravenous access. And with the GI, you might also want to ask about if he took any recent antibiotics and then developed fever and abdominal pain and diarrhea. Just keep in mind Clostridium difficile infection. So I think if we follow that approach, we wouldn't miss a lot in the history. And then you can ask about general symptoms like B symptoms or weight loss, night sweats. These also can guide you towards, for example, TB or malignancies. So coming to our patient, he didn't have any of those that I mentioned. He only had the fever, generalized body aches, but he also mentioned that he felt some palpitations and or a funny heartbeat. He didn't elaborate more on that. It wasn't associated with any other symptoms, no chest pain, no dizziness, no shortness of breath, and it was a brief episode that resolved on its own. He couldn't actually, know the rhythm of that palpitation, and he thought it's just associated with the fever, and it resolved on its own. So no further details were taken about the palpitations. Is there anything else you would like to add?
Okay, so let's stop here and let's go over this again. So this patient he's coming to you with fever, and then you have to know, is it subjective, is it objective, right? So sounds like he has some objective evidence. He maybe has a thermometer at home or checked his temperature somewhere, 38.7. So it's important to keep a track of this. Ask the patients whether they really, measure the temperatures. You get sometimes patients coming to you with complaints of fever, but no objective evidence. Some patients, those who come to you with months of fever, then you tell them to record the temperatures, and you just end up having like 37.3. So there could be other reasons. Then you want to have a list of the reasons. So infectious is one part, but you also have other systems or categories of fever. So autoimmune, drugs, medications, inflammatory, malignancies, even like blood clots, DVTs. So you all have to keep this in your mind when you're asking. The next point is this patient having fever for 1 week. So what was done? Did she seek any medical attention for this time? What was given to her? What investigation were done?
So the patient actually visited a GP 3 days before he was seen in ER. Some investigations were sent for him. He doesn't exactly remember what, and he was given paracetamol and PRN ibuprofen. Which he only took the paracetamol. He didn't follow up in the investigation, and he just came straight to ED.
Okay, so do we know what investigations were done? Was that part of our system?
So he said they took blood from him, and they sent a blood culture according to the patient, but he did not follow up, and they also did a chest X-ray, but he did not follow up with them. And when he was asked about if he was given any antibiotics, he denied that he wasn't given any antibiotics.
Right. So
what was the diagnosis that he was given?
Exactly, yeah.
I'm sorry?
What was the diagnosis that he was given?
So he was told that he might be having a viral illness and he should just rest at home and wait for the results to come. He will get called, but he just came to ER after that.
Okay, so Mira, do you have any questions? So you finish, the review systems, you finish the, so far what you have from the course, and then you want to ask, since, they're having Dr. Ahmed Hamadi today, so you're thinking maybe something infectious going on. So you ask about other things that may point you toward unusual infections maybe, or just other things you want to ask. So travel history you want to know, right? You want to know about what else do you want to know?
We mentioned sick contacts before.
Mm-hmm.
Okay.
That's one thing.
All right. So it's important to ask about the travel history and to which country he traveled to and what are the vaccines he took before that, and if he took any prophylaxis. He doesn't have any recent travel history. I think none of us have a travel history nowadays. And then you ask about the medications. He only takes warfarin, 5 milligrams daily, and he follows his INR. And according to the patient, it's always within the therapeutic range. He denies any allergies to medications.
No, Mohammed, before we go to the, the other histories. So travel history, as you mentioned, whether he took any, like malaria prophylaxis, any vaccinations for like hepatitis or yellow fever or anything that you think of according to the areas. Does he have any hobbies? Does he go hunting, camping? Does he, do anything specific?
So no, our patient doesn't do that.
Nothing, no hobbies that may point towards some, some kind of infection. So did he eat recently from outside, from like restaurants or?
So he doesn't go hiking or swimming in lakes or rivers or stuff like that.
Mm-hmm.
He just eats homemade meals. He doesn't remember eating from outside.
Okay, and there's no other family members with fevers or friends or that?
No family members, correct.
Okay. Okay. Did any consumption of unpasteurized dairy products or milk?
No, he denies that. He was asked specifically if he had any unpasteurized dairy products like camel milk or goat milk or anything like that, and he denies that. And he also denied exposure to animals in general.
So
he
no
doesn't have any
contact
pets.
to.
Yeah, and he doesn't
Okay.
go to farms.
Okay. What else? It's important also to ask about the sexual history, right? So this could be like something like acute HIV conversion, acute infection, or other, infections that may be acquired this way. And he denies that as far as we know.
He denies that, yes. He's married with 2 kids. He doesn't have any extramarital sexual relationships or anything. And he denies IV drug abuse or illicit drug use. He doesn't have any blood transfusion recently as well.
That's an important point. Okay, so the rest of the history you can tell us.
All right. Other than the things I mentioned, in the family history, there's no family history of malignancy or cardiac diseases, or like, for example, familial Mediterranean fever. I think it's important to ask about the ethnicity of the patient, because some genetic diseases can present with fever and generalized symptoms, and also because of where they come from. There are some pandemic diseases such as TB, so it's important to mention that. Our patient doesn't have risk for that. Social history, he denies smoking and alcohol intake. He just eats home-cooked meals, and his diet is adjusted to warfarin. He exercises regularly with no complications. As we mentioned, no recent travel history and no recent hospitalization or blood transfusions. He works as an accountant, and he's married with 2 kids.
Any recent changes in his medications?
No, he's been taking warfarin 5 milligrams since a long time, and his INR is controlled well. Whenever he goes checked, and they just continue the same dose.
So there are some certain medications that you have to, make sure patient is not taking things like, carbamazepine, hydralazine.
Yes.
Okay.
All right.
Have any
So
other medical issues?
Sorry?
Does he have any other medical issues or any past medical history aside from the valvular replacement?
No, he doesn't. This is the only issue that he has. He was asked about the medications even that can induce fever, and he denies any use of them. He denies recent antibiotics. He didn't take any rifampicins or phenytoin or sulfonamides or quinidines.
Okay, so Mira, what do you want to do next now? You get all your history and you have the patient in front of you.
Sorry, doctor, what did you say?
So what do you want to do now? Do you want to examine the patient, and what are you looking for?
Connection. Hello?
So I think we can hear you.
Mira?
We can't hear you, Mira.
Yes, Mira, can you confirm if you can hear us? Because we can't hear you.
Okay. Yeah, I don't think we can hear you. Maybe you can log out and come back again. I think Mira is back. Mira, can you hear us?
Her mic is muted.
Yes, I can hear you.
Okay, so let's resume. So, Dr. Muhammad, you want to tell us about the physical examination?
So the patient in ER, he was vitally stable. His blood pressure was 110/70, heart rate of 96, respiratory rate of 18, and temperature of 37.8. He says he took paracetamol before coming to ED, about 3-4 hours before coming to the emergency department. He looked a bit lethargic on general examination. He had a normal body habitus with no bruises on the skin and no stigmata of infective endocarditis. He didn't have any Janeway lesions, he didn't have ocular nodes, and he didn't have any hemorrhages per se. Also, he was normal. He didn't have any. I'm sorry. He didn't have anything on the head and ENT examination. Everything was within normal. And going down on the integumentary system, it was within normal. He only had the cardiac surgery scar, which looked healthy. Examining the lungs, it was normal with no crackles and at the bases and no reduced air entry bilaterally. On the GI system, it was within normal limits and he had no splenomegaly. On the cardiovascular system, a mechanical click was heard best at the mitral area with no diastolic murmur and no systolic murmur per se. And he didn't have any signs of heart failure. On the neurological examination, it was within normal limits with no focal neurological deficits and no neck stiffness or neck rigidity. All the other examinations were within normal. We couldn't localize a specific foci on examination.
Okay, so Mira, do you have any questions?
Can the mechanical click be due to the valvular replacement or is it pathological?
So say that
it
again.
is because of the valve.
The click, okay. So
Yeah.
I'd probably, done it, in a different sequence, because you want to keep your sequence when you're examining, especially with this patient. So start with the general inspection and describing the patient, then you go to the head ENT. So you will say that normocephalic, traumatic, look at the conjunctival pallor, no scleral icterus. Then you look at the neck, there's no raised jugular venous pressure or JVD distension, no thyromegaly, no neck lymphadenopathy. Then you want to look at the cardiovascular system because it's very relevant in this case, as you described. So you describe the heart sounds, and then you describe if there is any abnormal sounds indicating maybe valve dysfunction. and then you want to move to the the other systems, right? So GI should come after the respiratory systems. You look for any neurological findings, sensations, reflexes. You want to make sure, because you could have things like viral infections giving like transverse myelitis that will make you lose the reflexes, and depends where you are. You can get all kind of weird infections. So you have to be systematic in your descriptions. Don't forget about the joints, the lymph nodes, and the skin, if there's any skin rashes or any abnormal changes. Right, so you have your history now, you have your physical, and then before you go into the labs, you form some kind of differential in your mind, or things you want to look for.
Mira, do you have a specific list? Specific things you want to rule in or out?
So when they said that there's no reduced air entry, so I'd be thinking more about upper respiratory tract infection more than the lower respiratory tract infection.
Okay, that's one differential. I mean, when creating a list, you can either go by specific diseases or by systems, such as you can say infections and then mention upper respiratory tract infection, other infections that comes to mind.
What should always be in the list, on this patient? You want to make sure that you have things that you want to rule out all the time, right? He's a higher risk patient, so you want to have some differential that are always important to rule out.
So we want to rule out infective endocarditis, right?
Yes.
That's the most important differential in this patient because of his demographics and his previous history.
Right. You don't have any other symptoms, pointing toward the specific symptoms. You don't have any travel history. You don't have any animal contact, no consumption of dairy products, unpasteurized milk. He doesn't endorse any history of sexual activity that may now or maybe earlier pointed toward like HIV or syphilis. Or so you want to focus on these things. Then from the other systems, he doesn't give you any history of B symptoms or weight loss, or night sweats, or anything, specific pointing you toward autoimmune disease or maybe malignancy or other inflammatory processes, right?
Correct. The history basically was very, very vague and doesn't point toward a specific infection. But given his history, the most important one was infective endocarditis. But
so
we always
tell us, Mohammed, about the labs.
Okay. So in the emergency department, a complete blood count was sent, and his hemoglobin was 11 with a normochromic normocytic picture. His WBC's count was 16,000 with a left shift neutrophilia, and he had a normal thrombocyte count. Electrolytes and kidney function were also sent, where he had a mildly elevated creatinine of 120 and a urea of 9, with normal other electrolytes, including magnesium and phosphorus and calcium. And he didn't have any acidosis. CO2 was 22. And then inflammatory markers were also sent, which showed a CRP of 250 and a procalcitonin of 10. We don't have ESR, so that wasn't sent for him. Liver function tests were within normal limits. Coagulation panel showed an increased PT with an INR of 2.7, a normal APTT, and a D-dimer of 0.7 with a normal fibrinogen. He also had a strep A swab, which was negative. He also had a POCT for influenza A and B, which were also negative. His COVID as well was negative. The COVID PCR was negative on admission.
Okay, so Mohammed, before you go further, so Mira, do you have any other labs that you would like to do?
Cardiac parameters.
Okay, so tell us, Mohammed, about cardiac parameters.
Troponin and BNP were sent, and they were within normal limits. He had no increase in his troponin.
What about the ECG?
More importantly, is there anything else you'd like to send?
An echo?
Before the echo. So you're thinking, I was thinking about, infective endocarditis. So how do you diagnose it? What lab test you can send to help you with that?
A blood culture?
How many?
Yes.
How many sets you would send?
2.
At least 2. So at least 2. Okay. So Mohammed, let's go back first to the CBC. You have a white count of 16,000 and you said left shift. What do you mean by left shift?
The neutrophil count was increased. I think 80%, if I remember correctly, was neutrophils.
80%. So Mira, what's the normal differential for the neutrophil percentage in the blood?
For the neutrophils, it's about 50%.
Usually around 60%. So, and then how do you define, are you aware of the term left shift?
No.
So left shift means that when you have, immature cells, so it does not only specify the percentage of lymphocyte going up, because that's just an acute inflammatory response. So when you have immature neutrophils, things that come before the segmented neutrophils. So specifically, you're talking about bandemia. So anything above 6%, and then you look at other things that you may see. So toxic granulations, indicating, immature neutrophils, Dole bodies, which are released from the endoplasmic reticulum. You may see myeloblast or myelocytes, metamyelocytes. It's not supposed to see the more infection, but you focus mainly on, the immature neutrophils, specifically the bands. So this patient has leukocytosis, specifically neutrophils. We don't know if he has also bands or any form of immature neutrophils. His thrombocyte count is normal. The platelets count are normal, which can go down in cases of sepsis and maybe later stages like DIC. The kidney function is normal so far, or is it elevated creatinine of 120, right? So this indicates either low volume or maybe sepsis with underperfusion of the kidneys and extravasation, third spacing into the other areas. You have increased inflammatory markers. So Mohammed mentioned about CRP of 250 and procalcitonin of 10. Do you really need to do CRP? Not really, it's just a practice that's usual. Procalcitonin of 10, and it goes in, at all kinds of infection or bacterial or viral, or what does it tell you when you have an elevated procalcitonin? So Mira?
It goes.
I think it's not specific, right?
So the
It's not
procalcitonin
specific.
tells you if it's non-viral. So if it's low, that means it does not go up with viral infections. So that's very rare to go up with a viral infection. So it basically tells you that it is non-viral, but it can go up with bacterial, can go up with fungal, can go up with even, things like atypical infections like PCP and aspergillosis, maybe with the parasitics. The only viral that can give you higher procalcitonin is, COVID now that we know of. CRP is non-specific, so any kind of inflammation or stress reaction will give you. So pancreatitis can give you this, MI can give you elevated CRP. So you personally don't do it. Liver enzymes are normal. So, and then you have the INR 2.7, which is as patient is on warfarin, right? So you want to keep his INR between 2.5 and 3.5 for him. Okay, so Mohammed, tell us about the
Yeah.
blood cultures.
Okay, so he actually had 3 samples taken in the emergency department before any antibiotics were given to him. And on the second day of admission, like the next morning, it showed gram-positive cocaine clusters from the 3 samples.
So this is after how many hours?
It was about after like 12 hours. So he was admitted overnight, and in the next morning, it was showing gram-positive cocaine clusters.
Okay, so he does not have any central lines, and it's, as you mentioned, it's necessary to make sure that was this taken before or after antibiotics. Typically, it should be taken before any antibiotics are given, because that sometimes can affect the results. You want, for such patient, you want to make sure you have at least 3 sets. 2 sets will be also acceptable. 3 sets will be better. The reason is to improve the sensitivity of the culture. So things like one set will give you a sensitivity of somewhere around like 80, 75, 80%. 2 sets is maybe 85, 90%. 3 sets maybe 93, 95%. So you are trying to improve your sensitivity. You have gram-positive cocci clusters. So what comes to your mind? Which kind of organisms?
Staph aureus.
So Staphylococcus. So Staphylococcus, you have to keep it in your first maybe 3 differentials. Staph aureus, you know, and what other things, other kinds of staph?
Staph epidermidis.
So coag-negative staphs, right? So coag-negative staph are significant contributors to patients with prosthetic valves. And there is one particular one that we treated. It's a coag-negative staph, but we treated as Staph aureus. Do you know which one? It's called Staph
epidermidis?
No, it's called Staph lugdunensis. The reason Staph aureus is different because it has many, you know, pathological features, you know, pathogenic features that, like biofilm formation, and I think there is over 40 characteristics that will make it very aggressive. Okay, what other organisms you would think of? So clusters does not always mean staph. It can be other things also sometimes. So what other organisms that you also have to keep in your mind?
Streptococci, especially if he did any other dental procedures previously.
Okay, so you have strep, particularly strep viridans, and you can also get endocarditis from other kinds of strep, you know, strep pyogenes, it's likely strep pneumonia, but it has a prosthetic valve, so anything, you know, can be significant. What other type of gram-positives? So besides staph and strep, one more very important, Enterococcus. All right. So tell us, Mohammed, what was the result? I think, Mohammed, you are muted, I think.
Hello? Yeah.
Yes.
Yeah, so the second day after that, he grew Staphylococcus epidermis in the 3 samples that were taken.
So Staph epidermis. So and then that's 3 samples. So it's high. We consider this as a high load of bacteria and, you know, in the blood, and in this case it is significant. So before you go into the echo, tell us if you remember was there any ECG findings?
So ECG was done in emergency and it was within normal. He didn't have any heart blocks or sinus tachycardia or signs of LVH or RVH. This was actually within normal limits.
Okay, so what particularly, Mira, do you want to look at when you're looking at the ECG with patient with suspected endocarditis?
In ECG?
Yeah, and the ECG. Why is it important to do? What are you looking at? So if you get like a complicated endocarditis, right? So maybe with the valvular abscess or something extending toward the septum, you can have conduction delays. So particularly you want to look at the PR interval. So if that's prolonged, that can indicate conduction delays and complicated endocarditis. Okay, so Mohammed, tell us now, you want to do an echo, and do you want to start with a transthoracic echo, or do you want to start with a transesophageal echo?
Transthoracic.
You can do transthoracic, but having a prosthetic valve, that's an indication to go directly for a transesophageal echo.
It's more sensitive,
So
right?
it's a must to have a transesophageal echo, but sometimes it could be just easier to start with transthoracic, or depends on the availability, maybe like a weekend or something, and patient stable. So you can start sometimes with the transthoracic. So Mohammed, tell us what did we find?
All right. So, and the initial one was a transthoracic echo, which showed no vegetations, but it was a limited study. And then the next day of admission, he had a transesophageal echo done, which showed a 1 centimeter vegetation in the mitral valve, and it showed no signs of dysfunction of the prosthetic valve and no extension of the vegetation and no other complications. And he had a normal left ventricular function. It actually showed 1 centimeter vegetation in the mitral valve. He also had a chest X-ray, which was normal, just showed some cardiomegaly and the prosthetic valve. And he also had a urine analysis which showed microcephaly.
Okay, so Mira, what do you think now? Do we have a diagnosis of endocarditis, or do we have a criteria that that can help us to establish the diagnosis?
There is a criteria.
What is it called?
The Duke.
Duke's criteria. So modified Duke's criteria, what does it tell us?
We have to have a positive blood culture and positive findings in the echo.
Okay, so you have
Like,
pathological criteria, and you have clinical criteria, right? So 3
yes.
major, or 1 major, 3 minors, or 5 minors.
Yes.
Okay, so we
The fever, vascular abnormalities, and predisposing heart disease.
Okay, so we have evidence of vegetation in the mitral valve, which is the prosthetic valve, and we have microorganisms that are typical for this kind of infection. Right, there are other minor criteria that you can look at, but I think looking at this, I think this is enough evidence to say that the patient has prosthetic valve endocarditis, right?
Yes, so he has
Okay.
2 major criterias, and he also has the fever, 1 minor criteria. So he's already a definite case of infective endocarditis. Okay.
So we want to maybe to look at some organisms that are important to rule out in patients with prosthetic valve. So coag-negative staph may be one of the most common ones. Staph aureus. Again, we mentioned Streptococcus viridans and other types of strep, Enterococcus. You want to keep in mind things like resistant fungi, or just fungi in general, like especially yeast, things like Candida, other types of fungal infections. So Corynebacterium becomes also important in these cases. Pasteurella, which can come from dogs, Legionella. You can also have other rare causes of infections. So things like Coxiella. So you want to ask about animal contacts, right? Especially sheep. You want to find out if the patient has any diarrhea, that maybe point you toward rare causes like Trophorema whippley. So these are all, important. Gram-negative infections sometimes become important. Pseudomonas is rare, but it can be. It's possible. Proteus, E. coli, so Bartonella, Brucella, this Aspergillus. There's a very long list of pathogens that can give you prosthetic valve infection. But in this case, we know it's a staph epidermidis, which is one of the very frequent causes of prosthetic valve endocarditis. Okay, go ahead, Mohammed.
So our patient, after admission, he was started initially on empiric antibiotics before the identification of the bacteria and before the sensitivity came out. He was initially started on vancomycin and meropenem, and after the final results of the blood culture, when they came, he was switched to flucloxacillin, gentamicin, and then later on rifampicin was added. He was initially treated.
Yes, sir, yeah. Mohammed. So, okay, what Mohammed? Okay, so there was a suspicion for infective endocarditis, right? So, what was missing from the initial regimen? Okay, I would tell you that this
the
empiric treatment. So the empiric treatment in this case is not the best choice, right? So the empiric treatment for infective endocarditis, which should have been the working diagnosis since admission. So you want to have things like vancomycin plus gentamicin. You could start with rifampin also from the beginning. The reason is because you want to cover for biofilm forming organisms and the prosthetic valve infection, so hardware infection. So vanco, gentamicin, rifampin is adequate, or things you can start with things like daptomycin, which has biofilm activity plus gram-negative coverage. Gentamicin, which also provides synergy for staph infections. Okay, so Mira, what do you do next?
Dr. Ahmed.
After the empiric treatment?
Yes, after the empiric treatment. So you have a patient with prosthetic valve infection, right? And the echo is also showing a 1 centimeter vegetation. You look at the patient clinically and he's stable, he's maintaining saturation. The echo does not show any, regurgitation or, and the chest X-ray, there's no signs of heart failure, right? But it's a foreign body. So who do you consult and what do you do next? You adjust your antibiotics according to the sensitivities. And then what do you do next in terms of the monitoring and management? Who will be important to consult at this point?
Cardiology and cardiac surgery.
Okay, and what's the question for them?
Sorry?
What is your question for them? So the cardiologist, the cardiac surgeon asks you what do you want me to do, or what's your question?
The patient is a candidate for surgery for prosthetic valve replacement.
Okay, exactly, yes. So in the meantime, what do? You repeat the blood cultures, right? So you repeat 2 sets of blood cultures to measure the duration and to try to see the response for the antibiotics. You also want to look for other, seeding infections. So you want to ask the patient whether he has any, bone or joint pain, any, headache or changes in the, any neurological symptoms, any abdominal pain. So things like sometimes these vegetations will embolize and will go to certain places, may cause strokes or bleeding in the brain. They may cause septic emboli to the lungs. They may go to the abdomen, especially causing splenic infarctions. They may go to the mesenteric arteries, causing mesenteric ischemia and infarction. So you want to make sure you are keeping track of this, and you want sometimes to look for seeding infections such as joint infections, particularly sternoclavicular joints or vertebral spine. So you want to make sure the patient does not develop any complications. This patient particularly is on anticoagulation, so will be important also to check also the brain. Maybe a CT, at least a CT scan of the brain is not a bad idea to get a baseline. There is no bleeding in the brain, and because this also can affect the anticoagulation. So these are all important considerations, so you have to keep in your mind. You don't, so the surgeon comes in and from his side, there are some certain considerations that they also look at. So not every patient with prosthetic valve endocarditis would need surgery. So if the patient has staph aureus, early surgical intervention then is advised. Or if the patient has evidence of heart failure, or if the patient has some kind of big embolizations or big vegetations that require to be removed. Patients with, for example, we mentioned heart failure, patients with evidence of perivalvular abscess or heart block, or like aortic abscess, or some penetrating lesions, patients with resistant organisms such as fungi or highly resistant organisms, things like Pseudomonas, also Candida, or if you have a patient with persistent bacteremia, despite adequate therapy for 7, maybe 10 days, according to the type of the bacteria. So these are all candidates for surgery. So you want to keep this in your mind. In terms of the size, usually above 1 centimeter, but they sometimes give the patient a chance to be treated with antibiotics first, especially if the patient does not have any evidence of valve failure or evidence of heart failure. So these are all important considerations. So Mohammed, what was done for this case?
So after the identification of the bacteria that he had, his antibiotics were switched to flucloxacillin and gentamicin, and then rifampicin was added, I think, 4 days after that. He was given the 3 treatments for 2 weeks, and then gentamicin was discontinued, and he continued rifampicin and flucloxacillin for another 4 weeks. He didn't have, he didn't need any surgery, and he was doing well. His repeat blood cultures after 48 hours from initiating antibiotics were negative, and he never grew it again. He had a follow-up echo done 2 weeks after initiation antibiotics, which showed the vegetation is still there, but it was 0.8 in size, and no complications were seen. I think the patient made a full recovery after that, and he was advised about antibiotics prophylaxis, when to take it and which procedures he should be aware of, because he has 2 risk factors: a previous history of cardiac surgery and a history of infective endocarditis.
Yeah, right. So in this case, so sometimes we prefer to keep the rifampin later, and the reason is because of the staff tends to have a low level or low threshold to develop resistance to rifampin. So usually it's preferred to be added later. The gentamicin here serves as a synergy, and it's only preferred to be given for the first around the first 2 weeks, and then depends on your sensitivities to the penicillin or oxacillin. Then you may choose to give anti-staph penicillins, things like nafcillin or flucloxacillin, for the duration, and plus you have to keep in your mind the additional coverage with rifampicin. It's always important to follow up with the cardiac surgeon to repeat the echo to establish the new baseline in case patient develops fever. And as Mohammed mentioned, it's always important to keep this in the mind. So any patient, usually what we give to these patients is give them a card that says that this patient has a previous history of endocarditis, and he's at a higher risk. So anytime the patient has fever, he has to get 2 or 3 sets of blood cultures. So the patient has to keep this in his, in his wallet or his with him, and show it to like a letter from the physician to the next physician to just alert him about the higher risk. Follow up with cardiac surgery. They may decide for later on for a repair or to keep an eye on this valve in terms of repair or replacement in the future, or maybe repeat echo in the future. Does anyone have any questions?
So if Dr. Ahmed or Dr. Mohammed don't have anything to add, sorry, I would like to thank you all for this comprehensive and very informative discussion. And we will open now the discussion to the audience. If anyone has any question, please share them in the chat box.
Doctor, I have a question.
Go ahead.
Aren't they supposed to get on prophylaxis antibiotics?
Prophylaxis?
With popular replacement.
Okay, you mean in terms of just to keep him on prophylaxis?
Yeah, I mean after the treatment.
After the treatment, yeah, that's a good question, but I don't think it's necessary, unless patient is going for a procedure. So usually you treat the acute phase. I'm not aware that you need to give him anything, in the future, unless patient is going for, dental procedure or sometimes urologic procedure or hardware replacement for the joints. But usually, no, I don't think it's necessary.
Okay, so it seems that we don't have any more questions. Again, I would like to remind the attendees, if you have any questions to any of our speakers today, please email us the questions or share it with us on our social media. Many thanks to our speakers today, Dr. Ahmed and Dr. Mohammed, and of course, Mira. It was a great discussion and we all benefited from it. We would like to apologize again for the technical issues we had. We hope that we avoid them in the future. And thank you again for the audience today. We hope we meet again next Saturday with another interesting case. Thank you all, and have a nice day.
Thank you, everyone.
Thank you. Thank you.